Hi, I'm Colleen Hutchinson. I'm here with Marina Kurian at the 19th Annual Minimally Invasive Surgery Symposium at the Wynn Encore Las Vegas. Marina, thanks for being here.
Thank you.
Tell us a little bit about yourself.
I am a general laparoscopic, bariatric, foregut hernia surgeon in New York. I think that in Manhattan, and I have a academic appointment at NYU, Langone Health, and I'm excited to be here and talking about foregut and some of the bariatric stuff as well.
So let's dive right into foregut. The session that you have on GERD, you're talking about procedure choice, and the question really is, should the patients decide?
So that question, it should not be the patient's choice for the most part. I think that a lot of the testing that we do in foregut to assess the degree of a patient's condition, severity of disease, how reliably their symptoms match the reflux episodes or the anatomic issues that we identify, really just show that the workup is so extensive that it can't just be up to the patient, but it does have to be up to the patient and the surgeon most of the time. And I think with normal symptoms or classic symptoms, normal motility and maybe a hiatal hernia, the patients can certainly have anything, including like magnetic sphincter, lower esophageal sphincter augmentation, or have a fundoplication, and there are so many different types.
Switching gears a little bit to bariatric surgery and metabolic surgery, what is the first line therapy for when you get a call for a marginal ulcer?
So thankfully, half the time when I get a call about a patient having issues of either pain or nausea, and that can be one of the findings with a marginal ulcer, and so always usually have a gastric pain or they have severe nausea or intolerance to food. Half the time I get that call, the other half the time the GI has already gotten the call, done an endoscopy, and identified a marginal ulcer. And what most of the data in the literature show is that first-line therapy is really giving them a proton pump inhibitor, Carafate, to try and heal the ulcer, and that we go to surgery rarely. Now, even with a bleeding ulcer, can be managed with injections and then giving them PPI and Carafate to try and manage the bleeding, and it's also rare to go to surgery with that, but it's always something that we have to keep in mind, and be ready to take that on. And then the other thing with marginal ulcers is also perforation, and so if it's perforated, you usually have to go, but what the studies have shown is that we can actually just do a patch repair of the hole, and that should heal the majority of the time.
The line between advanced endoscopy and MIS is sort of blurring, and the many advances recently in endoscopy have sort of blurred the lines between the two distinct roles, or what used to be distinct roles, of endoscopist and surgeon. How do you see these roles evolving as these advances continue?
I think, both areas, so GI docs in general, a lot of them are doing diagnostic, some therapeutic, but not all are doing advanced. And the same can be said for surgeons. We do a lot of different things, but not all of us are doing endoscopy and advanced endoscopy. And I think that in order to really move the fields forward, we have to have that blend of advanced endoscopy both in surgery and more in GI as well. And I think ultimately, the tools and techniques that they're working with now, it's going to expand so that there's going to be a significant amount of endoscopic surgery being done from below, from above, and also through, if we look at, through the stomach or through the rectum type of surgeries.
So with regard to education and fellowships, would you say that with advanced endoscopy fellowships and surgical endoscopy fellowships, there should be both training by GIs and surgeons?
I do. We have a really strong surgical endoscopy leaders. We're lucky in this country, and also internationally there's a strong cohort of surgeons that do advanced endoscopy. And I think it is important for every fellowship to offer advanced endoscopy for their MIS docs, because this is something that we are capable of doing and we want to participate. And I think working with advanced GIs, it has to be collaborative.
Drilling down a little bit on that, would you say bariatric endoscopy is now a subspecialty of gastroenterology?
It's complicated, and I'm going to go as non-political as possible, but not every surgeon has a skill set to do advanced bariatric endoscopy. And SAGES and ASMBS actually have put forward a Be Safe curriculum, which is addressing that. And I was involved, so I am biased to say that I think that is important. And so if you are a bariatric surgeon, but you don't have the endoscopic expertise, you involve a gastroenterologist who does have the expertise. And then usually it's a collaborative effort. So I do think that just like in an advanced MIS fellowship, you need to have the collaboration between the two, because the advanced endoscopists, now they will, because there's been a lot of courses for advanced GI endoscopy and specific to bariatric, but they didn't always get the anatomy. And I think sometimes with the surgeon being there working together, you really get a better picture of what is going on.
So you and I both had the pleasure of speaking at Rory Pryor's Women in Leadership Conference, her second one in Philadelphia last August. And I know you're helping plan the third this coming year. How would you characterize the evolution of women in surgery and really specifically in leadership? And where are we today and what's needed?
That is we're having a full day symposium on that in October in New York.
So let's talk about it in 5 minutes.
So in 2 minutes or less, well, certainly there is more understanding that there's a disconnect between women in surgery and assistant professors, associate professors, and full professors. It's not just surgery, though. It's women in medicine. And Esther Chu is a ER doc out in Oregon, and if you guys are really interested, you can go look up Esther Chu Stanford Grand Rounds, and she gave a talk to the ER docs, but went through all of this about what happens and where's the drop-off, and why do women not advance. And when you look at corporate America, there's a lot of discussion around how women engage differently, ask for things differently, or don't ask because they don't feel they're ready, versus our male colleagues might ask even if they're not ready because it didn't occur to them that they're not ready and they shouldn't ask for a leadership position, right? So those same disconnects can happen in surgery and medicine, and so the reason we don't have as many associate professors that are women and full professors that are women, or chairs of departments, really has to do with that drop-off factor of why they drop off and who's evaluating them, how they're being appreciated, how they're putting themselves forward, what are the metrics and tools that they have and resources that they have so that they can go forward. And thankfully, just in surgery alone, there's at least 2 or 3 conferences around this. Actually, there's I think 3 or 4, and in medicine, they're doing this as well. And I think we need that and have that discussion. There's also different forums, for surgeon moms on Facebook, physician moms groups, another one. Just women in different specialties have their own groups, and it's helped bring out issues that are common to many. Issues that some weren't expecting, but others have experienced and can give advice. And so that will help move the needle forward, as well as he for she. That's very important. I think when you look at who you train and who you come and promote, it should be equal. You know what I mean? Like if you have, as somebody said, there's studies looking at female surgical residents, male surgical residents, and who was promoted and how. And it was pointed out, I always look at, my residents will probably complain, she does treat us like her kids. I look at them as my grown kids, and for me, I would find it incredibly difficult to promote my male child over my female child. I happen to have a boy and a girl. I would never promote one over the other, so I think that's something to keep in mind as he for she, as being an instructor, as being a leader in surgery, to make sure that there's parity and equity.
And I would say when we talked about this last year at that conference, I just spoke from a publication standpoint and went back and looked at how often I was asked by male surgeons, can I be a part of your on the spot? Do you want to interview me at MIS? Different things, versus how often females were asking. And it was so much more often males asking. And so I had said, to the residents and fellows who were at that meeting and the younger female surgeons at that meeting, ask for a seat at the table.
Mhm.
Pick up the phone, email, just ask if there's a column you like. If, in terms of getting involved in research, ask, because they need to hear that and they need to do that more. Is there other advice that you would share with them?
I would say that all of the studies are showing that diversity is so important with corporations, with hospitals. University of Michigan is doing a great job of having diversity and really changing that dynamic in terms of who they look for. And it's not necessarily who as in a he or she or a minority or anything, but they're really looking for diversity and bringing them in. They have a great program.
Yeah.
I think overall that is part of moving this forward.
Well, and I see on Twitter, University of Michigan has these courses, smaller courses, where they're really educating both males and females on this. And they're helping, with regard to males, they're helping in some of those courses teach them how to give more power to women as well. So
I would also say one last thing. If people feel like, I should, and actually people may feel that I should not be, but I always feel that my opinion or whatever I have to say is going to be of value, and I don't ever think that it's not of value. And I think that if everyone embraced that, we wouldn't have so much of this need to be inclusive, because there's some people who just go out and say, I have an idea and I think it's great, and other people are like, I have an idea but I don't think it's ready, and I'm like, I have an idea, I'm just going to let you know what I think, and that's
Right.
it. I'm just going to lay it out there.
Right.
So I think it's important to understand that you got to this place of finishing your training, doing your med school, residency, everything that brought you here makes you an incredibly valued member of society, and certainly of our medical society. So if you have thoughts, if you have questions, if you have like realizations, share them, because
Yeah.
it's very important.
Well, thank you for being here today.
Thank you.